Endoscopy in patients on antiplatelet or anticoagulant therapy, including direct anticoagulants. British Society of Gastroenterology, BSG, and European Society of Gastrointestinal Endoscopy, ESGE, guidelines. Origin and purpose of these guidelines. Anticoagulants and antiplatelet agents are widely prescribed for a number of cardiovascular and thromboembolic conditions with established benefit to patients. These drugs confer an increased risk of hemorrhage when undertaking therapeutic endoscopic procedures, but also pose risks of thromboembolic sequelae if discontinued. The British Society of Gastroenterology, BSG, published guidelines on the management of anticoagulants and antiplatelet agents in patients undergoing endoscopy in 2008, and the European Society of Gastrointestinal Endoscopy, ESGE, published guidelines on endoscopy and antiplatelet agents in 2011. Both guidelines are due for revision, and the BSG and ESGE have cooperated to produce a joint guideline. Since the publication of the previous guidelines, there has been an expansion in the use of the newer antiplatelet drugs, and new oral anticoagulant drugs have been introduced. The latter have been widely prescribed and pose particular problems for endoscopists with regard to hemorrhage. Their effects are difficult to reverse in an emergency situation, and moreover, some of these drugs are associated with a higher incidence of spontaneous gastrointestinal hemorrhage compared to warfarin. Preparation of the guidelines. These guidelines were drafted by a working party comprising members of the BSG and ESGE, a hematologist, interventional cardiologist, and a patient representative from the charity Anticoagulation Europe. Guidelines were prepared according to agreed-to principles and comply with the requirements of the National Institute for Health and Care Excellence, NICE. Clinical questions were formulated using the PICO, Patients, Interventions, Controls, Outcomes system. Search strategies were delegated to authors with responsibilities for specific sections. Literature searches were conducted using PubMed and Ovid, Medline, Embase, and Cochrane Library. Additional searches were conducted using Google. Literature searches were rerun in February 2015, and any additional relevant studies considered up to August 2015. Quality of evidence and strength of recommendations were determined by the authors and consensus achieved according to the grade system. After agreement on a final version, the manuscript was subjected to internal peer review and revision by the BSG and the ESGE and sent to all individual ESGE members and member societies prior to publication. Conflict of interest statements were submitted by all authors. This guideline was produced in 2015 and will be considered for review in 2019 or sooner if new evidence becomes available. This guideline has been co-published with permission in both gut and endoscopy. Summary of recommendations. The new recommendations are based on best estimates of risk-benefit analysis for thrombosis versus hemorrhage. When discontinuing antithrombotic therapy, patient preference should be considered, as well as clinical opinion. The risk of a potentially catastrophic thrombotic event, such as a stroke, may not be acceptable to a patient even if that risk is very low. For all endoscopic procedures, the authors recommend continuing aspirin, moderate evidence, strong recommendation, with the exception of ESD, large colonic EMR greater than 2 centimeters, upper gastrointestinal EMR, and ampulectomy. In the latter cases, aspirin discontinuation should be considered on an individual patient basis, depending on the risks of thrombosis versus hemorrhage. Low-quality evidence, weak recommendation. 1.1. Low-risk procedures. For low-risk endoscopic procedures, the authors recommend continuing P2Y12 receptor antagonists, e.g. clopidogrel, as single or dual antiplatelet therapy. Low-quality evidence, strong recommendation. For low-risk endoscopic procedures, Veitch et al. Suggest that warfarin therapy should be continued. Low-quality evidence, weak recommendation. It should be ensured that the INR does not exceed the therapeutic range in the week prior to the procedure. Low-quality evidence, strong recommendation. For low-risk endoscopic procedures, the authors suggest omitting the morning dose of DOACs on the day of the procedure. Very low-quality evidence, weak recommendation. 1.2. High-risk procedures. For high-risk endoscopic procedures in patients at low thrombotic risk, the authors recommend discontinuing P2Y12 receptor antagonists, e.g. clopidogrel, 5 days before the procedure. Moderate quality evidence, strong recommendation. In patients on dual antiplatelet therapy, it is suggested to continue aspirin. Low quality evidence, weak recommendation. For high-risk endoscopic procedures in patients at low thrombotic risk, the recommendation is to discontinue warfarin 5 days before the procedure. High-quality evidence, strong recommendation. Check INR prior to the procedure to ensure this value is less than 1.5. Low-quality evidence, strong recommendation. For high-risk endoscopic procedures in patients at high thrombotic risk, the authors recommend continuing aspirin and liaising with the cardiologist about the risk-benefit of discontinuing P2Y12 receptor antagonists, e.g. clopidogrel. High-quality evidence, strong recommendation. For high-risk endoscopic procedures in patients at high thrombotic risk, the authors recommend that warfarin should be temporarily discontinued and substituted with low molecular weight heparin. Low-quality evidence, strong recommendation. For all patients on warfarin, the authors recommend advising that there is an increased risk of post-procedure bleeding compared to non-anticoagulated patients. Low-quality evidence, strong recommendation. For high-risk endoscopic procedures in patients on DOACs, the authors recommend that the last dose of DOACs be taken at least 48 hours before the procedure. Very low-quality evidence, strong recommendation. For patients on dabigatran with a CRCL or eGFR of 30 to 50 milliliters per minute, the authors recommend that the last dose be taken 72 hours prior to the procedure. Very low-quality evidence, strong recommendation. In any patient with rapidly deteriorating renal function, a hematologist should be consulted. Low-quality evidence, strong recommendation. 1.3. Post-endoscopic procedure. If antiplatelet or anticoagulant therapy is discontinued, then the authors recommend this should be resumed up to 48 hours after the procedure, depending on the perceived bleeding and thrombotic risks. Moderate quality evidence, strong recommendation.